Okay, I'll start us off. So one of the beauties of ARK and the NILT survey, so it's really great, thanks to the team to start this off, is in getting to fund a module, we also get access to any kind of cross-analysis or any wider picture that would create for mental health with the other elements. But this seminar today is just about the questions that we put in and why they were necessary, or we felt they were necessary. My name is Dr. Nicole Bond. I'm from the Mental Health Champions Office. I'm the research officer there. And throughout the work that Siobhan does, and she'll go through it all in more detail, is trying to ensure that our mental health services are fit for purpose, that people are getting access to the services that they need. But there really is a gap in understanding what that is and what people's experiences are. So we thought that if we could include questions of that nature within NILT, we could get that wider picture. So there's questions on general mental health, general well-being using the WHO-5 scale, and that's a scale that has been used in other research studies as well. So it allows us to compare results to other studies in the area in further analysis as well. And then meeting the legal definition of victim or survivor. So the Commissioner for Victim and Survivor did a population-based study in 2021. And obviously we know that trauma and the impact of the conflict here has impacted a lot of people across generations. So we wanted to capture if the levels were still similar to those that were present in that 2021 survey. And then we wanted to check if, regardless if they meet the legal definition for victim or survivor, because that's very specific, if they felt that the conflict had impacted their mental health in any way. Then we wanted to look specifically at people who have accessed support or have tried to access support for their mental health at 2 time periods. So we focused on any time since October 2021 in that 2 years. Because a lot of things have changed over the COVID period, and just a lot of things have changed within services in general. So we asked if they accessed support, what was offered, who provided it, and how long it took to get an effective treatment. So a treatment that they felt led to an improvement in their mental health. And then we asked the same questions from any time before October 2021, so that's across the lifespan. And we allowed them to say it could take 10 years or longer, but you'll see all that as we go through. So I'll give you a brief overview of those initial questions, and then Siobhan will take over to go into detail what that means in a policy context. So general mental health, they were asked how they would rate their mental health from excellent to poor. Over 75% would say they have excellent, very good, or good, but you can see that across our different groups that changes. So if they've been impacted by the conflict, that is, or their mental health has been impacted by a conflict, they're reporting lower levels, fair or poor. And if they did seek support since October 2021 or sought support before October 2021, they're reporting lower levels of mental health anyway, as you can see. So sought support for, sorry, my numbers aren't coming up. But if we look at the sought support from October 2021, where anyone from excellent, very good, or good is coming up at just over 50% rather than the 75% that was for the general population. So there's a difference there. Saying that we used the general wellbeing score from the WHO-5 index that asked 5 questions about how they would view their wellbeing over the past 2 weeks. It asked how their sleep was impacted, if they felt active or vigorous, if they felt like they were able to get enjoyment out of their daily life. And from that, you get a wellbeing score. So the best well-being is 100, the lowest well-being is 0, and we found that 70% have a well-being score over 50, so that would be good well-being. But as you can see, when you subdivide it into the other groups, that changes quite significantly. So if their mental health's been impacted by the conflict, their general well-being is lower. If they've had to seek help for their mental health before October 2021 or since October 2021, their general well-being is lower. So we're getting a picture of the level, the nuances to what's driving the poor mental well-being. It's not the full picture, it's far from the full picture, but it's given us an insight in our population of what could be pushing this as well. So we know that from our survey, we said that 29.9% of the population had felt that their mental health was impacted by the conflict. Now, that was regardless if they met the legal definition or not. This was higher for our males, which a lot of the wellbeing figures, it's the females are coming out as higher. They have poorer wellbeing overall, but specifically relating to the conflict and the impact of mental health, our males are more likely to be impacted. Sorry. So it's 35.9% compared to 22% of females, so it's quite a significant difference. We only found that 17.8% meet the legal definition of victim or survivor of the conflict here. Now, the CVS study did find a higher number, that's 29.2%, but we do think that there's a bias in the result because the CVS study is only targeted at people who are victims or survivors of the Troubles and trying to gather that data, whereas this is a whole population level that we were looking at through ARK. And again, those who reported that their mental health was impacted had significantly poorer wellbeing overall. Oh, sorry. Won't let me go across. Okay, so we asked then if they did access support, where were they getting that support from? Overwhelmingly, it's through our GP services, and if anyone working in that field, we know that our GPs are usually the first port of call or where people are directed to when they're looking to seek for support. But then 10% would be going through the community and voluntary sector, private practitioner and adult mental health services, and a very small number going through our emergency services. So this is really painting a picture of the access routes, the pathways that people are taking. And it's interesting because we know that a lot of emphasis is put on the emergency services and mental health crises in that area, when really we're getting a bigger picture. It's going through our GPs, it's going through other areas, and we need to recognise that those are providers and the work that they're doing as well. So I'm going to pass over to Siobhan, because what all this means in terms of our policy context and then the individuals seeking support at both time frames will have a lot of bearing on what we do moving forward, and Siobhan is the woman that can tell you all about that. Sorry.
Okay, thank you for that. Mind yourself.
Try not to break the
Okay. So we're starting with mental health services. So if you're even going back here to these numbers, a lot of people will be going to their GP and then something else. These don't add up to 100 exactly. So, but when we see the conversation about mental health services, GPs and primary care are very rarely mentioned. And I think that's one of the standout findings here. We knew this. When you look at the data and the evidence, you know that that's how people are accessing mental health services in there. And in primary care, that's where people are going first. But a lot of them are actually maintained within primary care and nowhere else as well. So we're going to have to dig down into the data to find out about, you know, the types of the individuals that are going to each of these different services and what they're receiving. And our numbers are very small, 227, so it's very difficult to get the comparisons and to do the statistical tests there. But you can see very clearly primary care is a main provider of mental health services. C&V sector, 1 in 10. Private practice is a very interesting one, 8.9%. And again, when we talk about mental health services, we know people are paying privately, but we had no idea previously around the numbers who were seeing private practitioners as well. Adult mental health services, these are our statutory mental health services. What people think about traditionally, it's secondary care, it's NHS. The adult mental health services are really, they're really for people who have moderate to severe mental health problems, who would meet the criteria for a mental illness, a diagnosable mental illness that's at a more severe level, where they would merit secondary care services. And then the C&V sector, we know that they provide a lot of work across all tiers, and that's unlike other regions, even regions of the UK, where C&V sector will be doing a lot of the mild to moderate work. In Northern Ireland, C&V sector actually work across those different levels. right up to severe trauma-related mental health services, and specialist services would be provided by the C&V sector as well as services for people who, by the nature of their difficulties or trauma, they would have particularly significant and severe mental health problems. And I'm thinking about the likes of Nexus there, and some of the organisations who deal with groups in the population who are very high risk, and victims and survivors, of course, of the Troubles as well. And 2.1% going through emergency services, that actually probably should be a lot lower, because emergency services are really there for people who are in crisis. So that, even though it appears low, that is an important percentage if you extrapolate that out across the whole population. You know, really nobody should be accessing mental health services through an emergency department, and that is a cause for significant concern as well. Okay, so that's just a wee graph of that. So what does it tell us? We need to prioritise multidisciplinary teams in primary care, because as most of you will know, primary care is under an awful lot of pressure at the minute. It can be difficult to get that initial appointment with your GP, and receptionists are often tasked with asking the probing questions to help work out whether this person needs a telephone consultation or a face-to-face consultation, and who the right person is in the practice. So, I mean, the MDTs are working in certain parts of Northern Ireland and working reasonably well. There are difficulties in some areas, but mostly they're working quite well. So we need to prioritise the rollout of those MDTs in primary care so that people can get access to a mental health specialist in that setting. And it is appropriate that primary care is the main provider there, because they need to be doing all those initial blood tests and physical tests, because often mental health symptoms are actually symptoms of a condition that needs managed physically, as opposed to a mental health problem per se, and that diagnosis would need to be done within primary care. So we need to equip our primary care teams for this work. And certainly, you know, if we look at the concerns that the Royal College of GPs have at the minute around the delivery of primary care services, that's a significant worry for somebody like me who's interested in making sure everybody gets the right care. We have a growing private sector, and if you look at our mental health strategy, there's really very little recognition of the role of the private sector, and I think that's a conversation that we should be having. So in addition to the private sector, there's also workplace mental health services, there's student mental health services, so there's a lot of other services there that are delivering this care. So how do we create a system of mental health care that acknowledges all these different places, and making sure there's not duplication, so that people get to the right services quickly and as efficiently as possible. And you know, there is some evidence that when people are paying for their therapy, they're more likely actually to have a positive outcome. So, you know, there's some interesting stuff there as well. I would believe that mental health services should be provided free at the point of delivery, but there is room for the private sector. There's got to be room for the private sector somewhere there anyway. C&V sector are as important, you know, if you look at the data, they're as important as adult mental health services in terms of the proportion of the population who are accessing services, yet they're constantly under threat. You know, most of those organisations are struggling for funding. They don't get 3-year funding pots. They get funded on an annual basis. So that again, it's a really worrying situation when they're delivering 10%, nearly 10% of the mental health care and effective mental health care at that. And then of course we have statutory adult mental health services as well, and our emergency services. And for me, the proportion going through emergency services really needs to be reduced. We have a plan for a regional crisis intervention service that joins up all of the emergency responses, including police, ambulance, rescue organisations and emergency departments, psychiatry liaison, GP out of hours, all of those services, to create a system that provides effective support for people, and a no wrong door system. And the idea is that with that there would be follow-up within the C&V sector for people people who don't meet the criteria for an admission, that there will be follow-up there for up to 14 days after a crisis presentation, problem solving, safety planning, suicide prevention work. So the Regional Crisis Intervention Service model really is it's very impressive, and that's what we need to be bringing in there to reduce the burden on emergency services. Because whilst that's a small enough number, we know that for some people they're going to the emergency services again and again and again, and they're in that cycle, and we need to make sure that they get the effective support, because that's associated with a high risk of suicide, death, people who are in that group as well. Overall, the mental health strategy sets out the vision for a single regional mental health service that incorporates all of these different elements and links them all together, and also provides links with schools and provides alternative points of access to mental health services, such as through crisis cafes or community walk-in clinic type models, and that's what we need to see, so that all of these are integrated together and they're all working under the same frameworks. The regional outcome framework, for example, is applied across all of these services. So that's what we need to deliver ultimately. So what interventions were offered? Now this is really interesting, because we can then look at what people are saying they were offered, types of treatments, and what's recommended for various different mental health conditions. So what interventions were offered? So I'm using the term here non-pharmacological intervention for anything that's not a medication. So traditionally people might see this as counselling or talking therapy or psychotherapy. So NPI refers to all of that. It also refers to digital mental health therapies, and you'll see later on when I talk about what should be recommended that there's some good evidence and even nice guidelines around those as well. And social prescribing, support groups, self-care, all of that's incorporated within NPI. So that's how we've divided it up. So ideally people would be given a choice, and in this survey we found that both medication and NPIs were offered to around a third of the people who sought support with their mental health. Now that has actually gone down since 2021, and it was higher than that. So that's a little bit worrying. Now we were asking what was offered, not what people take up, and we know that sometimes people are offered counselling or they might be offered medication and they decide not to do that. So we're hoping that when these questions were being read out, or they're not being read out, they're online, that people actually read the question and answered what they were offered rather than what they decided to take. So there's always a bit of a worry, about how people interpret these questions. So both medication and NPIs were offered to around a third of people. Medication was offered to 66, two-thirds, since 2021. That's gone down a bit since in the year before the pandemic, before the two years. So that's gone down a little bit. Medication is an appropriate intervention if you look at the NICE guidelines, the clinical guidelines, but there is concern about medication and the effectiveness of medications, the risk of suicide, the fact that medications often have side effects too that people have to deal with, but nonetheless it's still a recommended treatment for moderate to severe, and I'll go into that in a bit more detail in a minute. Right. Oopsie daisy, sorry. That should be us now. So medication was the only intervention offered to a third since 2021, and that hasn't changed much in the years. So whilst we're trying to invest more in mental health services, and if you look at the money that's been put into mental health services, that has increased a little bit in recent years, it's still not affecting on the ground what people are offered, in this sort of population survey. So medication, the only intervention offered to a third. And we don't know why that was, and maybe that was that there were no other interventions available, or the GP didn't know about them, or whoever was doing this didn't know about them, but that's what we found. MPIs were offered to over half since 2021, and again it hadn't changed much in the period before that. So MPIs should be available for the whole population. I mean, ideally, we would have a suite of online interventions that, at the very least, information would be offered to people. So MPIs should be offered to everybody. And I'm not saying that everybody needs psychotherapy. That's certainly not the case. Absolutely not. But if you look at the whole range of MPIs that should be available to support people's well-being, then if someone's coming with a mental health difficulty, then we should be in a position to offer something to everybody that's not medication. I would argue. Okay, so MPIs were the only intervention offered to about a quarter since 2021, and that has increased from about 1 in 5 to if we compare prior to that period. So I think the combination, the idea of medication still very much being used and being offered there for people with mental health difficulties. So if we look, and I think this is interesting, let's just look at the table on the left. When we look at since 2021, or the little graph on the left, we can see there that males, there's a gender difference where, let me just check it, so males are more likely than females to be offered non-pharmacological interventions, the purple line there, so that's interesting. And we know when we look at the rates of prescribing for females, like that sort of middle age group, the 40s, you've got a situation where nearly 4 in 10 women have an antidepressant prescription. That's really high, and it may be that this is a preference that people have, people have asked. The women have more likely to ask for this, and then therefore they were offered it. But I found that very interesting. We need to dig down a wee bit more and look at the actual mental health scores as well, and really work out whether these were appropriate or inappropriate prescriptions. But I just find the comparisons interesting. People who were victims, who met the definition for being a victim or survivor of the conflict, were much less likely to be offered no support, so that's a good thing. But it probably is because their mental health needs were greater, as we see in the earlier sets of slides as well. And again, people whose mental health was impacted by the conflict were more likely to receive something or to be offered something there as well. So there's differences in the different groups, and there is a gender difference there as well. So let's look at what let's think about the accuracy of the I suppose the what would you say, the effectiveness or the appropriateness of these interventions that we're talking about. So way back in the day, we did a study, and now it was a long time ago, and we discovered that around 7.9% of the population had major depression and 9.6% had any mood disorder. And you can see there the proportions that met mild were 19.6%, 37.3% for moderate, and 43.1% for severe. So if we assume that this kind of still stands in terms of severity, the NICE guidelines really say that for mild depression or moderate depression, that medication shouldn't be the first thing that people are offered, or shouldn't be automatically provided. So you can see this is from the NICE guidelines. These are all the different types of therapies that should be available within mental health services. Everything from self-help to group therapy, behavioural activation, group exercises, interpersonal psychotherapy, and then we have antidepressants here. So this is like your escalation of severity. And then you've got counselling, short-term psychodynamic psychotherapy. So there's so many different options there. And what NICE are saying is, yes, you need to discuss treatment options. And if somebody has a preference for treatment, a particular type of treatment, then that should be used as a basis. But down here they're saying do not routinely offer antidepressants as a first-line treatment unless that is the person's preference. And what we're seeing is that 2/3 of people are offered antidepressants, and that the likelihood of all of those people having moderate or severe symptoms is slim. So there is still a sense that antidepressants are been used where other interventions should be used. It's not that it's inappropriate, maybe people wanted that in the absence of everything else, but we should be able to provide all of these within our mental health services. So I'm not saying that people shouldn't take antidepressants or shouldn't be offered antidepressants, but I'm suggesting that those numbers really look high when we think about the proportions with mild, moderate and severe depression that are likely to be in that group. The most common mental health problem that people will have in any population is your anxiety disorders. And in Northern Ireland, the same study that was now, and it's really out of date at the minute, but you know, it's the best sort of information that we have around severity symptoms. 14.6% had an anxiety disorder, a third mild, a third moderate, and around a third severe. So again, many of those people who are going for symptoms with their mental health, going to their doctor or seeking services, many of them will have an anxiety disorder or depression. Those are the two most common ones. And a third of them will have mild anxiety disorders. Now, if you see there, this is directly pasted from NICE, and they don't have they don't have a neat little diagram for anxiety disorders. And this one is for PTSD. You can see there medications and drugs are recommended in certain situations, but it's only really, even for PTSD, it's only where there's no other psychological treatment or if psychological therapies haven't worked. So again, what I'm saying is that many of the people who are presenting, if they have an anxiety disorder, will have a mild anxiety disorder, and again, medication probably wouldn't be recommended for those people unless it's their preference. So we have a lot of prescribing. So time taken to access effective interventions. This is another one that we hear a lot about in the media, people waiting a long time, but it's very, very difficult to get the accurate data on waiting times in Northern Ireland because the trusts all define waiting, and could be waiting after assessment, waiting for an assessment. It's measured in different ways in each of the trusts, so we can't easily bring all that information together, and we have tried, and you need to manipulate that data in order to get a sensible kind of overview. And then of course there's waiting times for C&V sector services, and again it really varies depending on the service, and there's no central database of how many people are waiting on a mental health service. So this was a really important part of our study, was to actually ask people, how long did you wait? And not how long did you wait until you received something, how long did you wait until you received a service that led to an improvement in your mental health? And this was taken directly from the World Mental Health Surveys, because that's the sort of question that they ask. You know, how long did it take for you to get a service that made a difference? Now, in Northern Ireland, the guidelines are that people should receive a mental health service within 9 weeks. It's a 9-week kind of target. Now, the appropriateness of that can be debated as well, because certainly if someone's suicidal or in crisis, I would be saying that they should be getting a service very, very quickly indeed, because that person might be very, very high risk. And in our regional crisis intervention service, again, as I say, there's that sort of 14-day after presentation that you get the service starting the next day for 14 days, or you get an immediate admission, or you get a referral to a mental health team who will get you seen quickly because you have a mental illness that needs treatment. So the time taken to access effective interventions is very, very important information to have. And in our study, we found that 54.6% received an intervention which led to an improvement within the 9 weeks. So, and that has just got slightly, just slightly better since the period before October 2021. So we can't really say that things have gotten much worse based on this data. And certainly it doesn't match the narrative that I'm sometimes faced with, that there's nothing. Services are non-existent. Clearly there are a lot of people who are getting services, and effective services, within that 9-week period, and that's positive. But, you know, let's think, if this was another illness that we were talking about, if this was a cancer deadline, you know, a cancer target for, you know, the 2-week red flag referral target for cancer, would we accept 46.3% not being seen within that timescale? I would argue no. These are treatable illnesses that have a significant impact on people's functioning and in their work and their roles, and they impact everybody else around them, and people deserve effective treatments. And 9 weeks is long enough to be waiting for a mental health service or for a treatment or for something that would make a difference to your mental health. And you know, an effective treatment, that can be a medication, and we know medications don't start working really for a few weeks after the person starts to take them. So, you know, that's the time they received a treatment that worked, but that's not the time to the treatment actually made a difference to them, if you know what I mean. So if the question was interpreted correctly, you know, we have people starting treatments at 9 weeks and then getting a difference after a period of weeks or months from those treatments. So basically it's not good enough, but there's a lot of really good work happening in the system to get people effective treatments very quickly, relatively speaking, and that needs to be said as well. But we need to do better, and we need to work out why the others aren't getting the care that they need within the right time period. The 9 weeks is one thing, but we did find that nearly 70% there, nearly 7 in 10, got effective support or treatment within 6 months. So again, that's quite good, because when we look at how mental health services are discussed, this is lost, this isn't captured, the numbers who are receiving effective treatments within 6 months, within 9 weeks. But sadly, we have this figure here that 11.5% have never received an effective treatment, and that was only included in the since 2020. It should be prior to.
So 11.5% haven't received any treatment that they saw benefit from since 2021. So that's over the past 3 years.
Mm-hmm.
When we asked for the before time period, we allowed people to tell us if they received anything within 10 years or 10 years or more.
It's on the next graph, yeah.
So it's 8.9% never, and 11.5% never in the past 3 years.
Okay. So, but still, we're talking about 1 in 10 people who've never received an effective treatment. Again, when you look at the efficacy of treatments, it's really interesting. There's a review by Pim Kipper. I retweeted it the other day, but it was fascinating. It showed that even the psychotherapies tend to have an effectiveness of 30 to 40% when you look at the scientific studies. Equally with antidepressants, only about a third of people benefit from the first antidepressant that they try. Often people need to try different things. And there is a thing that is treatment-resistant depression, that psychiatrists will use that label for people. But should it be 1 in 10? I would argue that after a period of years, most people should be able to find a treatment or a combination of treatments that are effective, and that number should be a lot lower than that. So this is a really mixed picture. There's a lot of really good work happening out there, and people are receiving treatments, but certainly it's the earlier people present, the better. We want to get people into the system earlier so that they're more likely to get a treatment that works. And we know the more severe, the longer you leave it, the harder it can be to treat. People pick up comorbidities. They start drinking or using substances to manage their mental health symptoms. Things get worse. They get into worse cycles and more entrenched cycles of behaviours that consolidate the poor mental health that they already have. So early intervention is better. Which is why you would want to be trying to get this up as high as possible. So that's our little graph where you can see there for our different sectors. Let's look at victims or survivors, that green group. A lot of them are, so that this is within 9 weeks. One, so you can see their victims and survivors are above the general population is the orange. So there's more victims and survivors getting help, which that's good, because that hopefully reflects our victims service and the regional trauma network, who are now delivering services to that group. So people are getting services. Oh, that's no. Sorry, it should be yes. That's a is it?
So the
yeah.
victims or survivors are getting, they are getting support, but it's taking longer.
It's taking longer, yeah. Okay, so they're on waiting list. I thought that was good. Sorry, whoops. No, that's really, yeah, that's not good at all. Females are taking longer. So victims and survivors are taking longer. Females are taking longer. Males are getting help more quickly. That's a trend throughout all of this, I think. So the interpretation of the victims and survivors is that they're needing more advanced therapies and they're waiting longer for those, which is not good. And that hasn't changed much since 2021. It's got a bit better. But it's not as good as you would want it to be. Okay. So, in terms of discussing the waiting time, so the 9-week target wasn't met by 46.6% since October 2021, 45.4% before October 21. That's not good enough. More than 1 in 10 have never received an effective intervention, and lower proportions of victims and survivors received interventions in 9 weeks. So that means they have more complex needs. Higher percentage of males receiving effective interventions in 9 weeks as well. So why are women not getting effective interventions? And we know we can map that onto medications as well. But there's all sorts of other explanations for that. And if you look into the literature around women's mental health, you can see that women are more likely to be carers, they're more likely to have multiple responsibilities. There's also factors around the menopausal transition in that age group, and the prescribing of antidepressants for menopausal symptoms perhaps. That could explain that. And when you look at younger women, there's evidence around sexism and misogyny is contributing to poor mental health in that group as well. Okay. So in terms of our discussion, this is a relatively small sample, and you can see that in some of those subpopulations, the numbers are really small. So it's very hard to do statistical tests that will highlight these differences because the cell counts are so small. We don't have information on the severity of the mental illness that that person has, or the diagnosis. So, for example, people with PTSD, they should not be treated. Certainly moderate to severe PTSD would need a specialist service, trauma-focused therapy, EMDR, and that's what's recommended for PTSD. So they would, people with those conditions might have to wait longer for the right service. And we know that there are inappropriate referrals that still happen. So some of the data from Department of Health shows that around 30% of referrals to mental health services are inappropriate for the statutory mental health services. So we would need more information on severity and diagnosis to understand exactly the kind of the story behind some of these waiting times and the types of interventions that people are being offered. There's missing information on the type of MPI and the diagnosis as well. It's not appropriate if someone's got severe depression to be offering them social prescribing necessarily and isolation. People need to be matched with the right type of treatment, and we know that there's gaps in specialist services. So again, that might help explain some of these patterns. So the certain and sure conclusion that we can reach is that there's a need to improve mental health services so that everyone can get the recommended interventions in 9 weeks. And if that happens, then they will be in a pathway to the type of treatment or support that's going to make a real difference to their mental health, and that data would be captured in a study like this. So what you'd want to do is roll this out maybe in a few years' time. If the mental health strategy is implemented correctly, then there should start to to be changes there. And ultimately for me, this does support the need to implement the mental health strategy, which is the plan to transform mental health services and make sure that there's no wrong door, that everybody can access the service they need, that everybody has a choice of effective services, and gets the benefit of those services as quickly as possible, so that their functioning isn't impaired for an extended period of time. So I'm going to leave it there, and we will take some questions now, if that's okay.
Thank you very much.